welcome to my maternal postpartum assessment video. A couple of things I would do before entering the mother's room. I would check the physician's orders and the client care plan. I would also check for previously documented vital signs, just so I know offhand, so I can compare them to whatever I find. And I would also gather any equipment I would need to complete the assessment. For today's assessment, I would need a blood pressure cuff, a stethoscope, and a reflex hammer, but for the purpose of this video, I don't have one, so we'll be using a remote. So once I enter the room, I would identify myself as the nurse for the day and what I would be doing with the client. So I would just say, "Hi, my name is Noelle, I'll be your nurse for today, and I'll be performing a postpartum assessment on you." I would ask the patient to identify themselves, and I would compare their answers with either their hospital bracelet or against their medical charge, probably both. I would ask the patient if she needs to empty her bladder before I begin the assessment, and then I would help her if she needed. I would also provide privacy by either pulling the privacy curtain, or if she's in a room, I would close the door. I would perform hand hygiene before I do anything, and then I would adjust the bed to a comfortable working height for myself, and then make sure that the mother is laying in a supine position. So before I begin, I want to remember that throughout the entire physical assessment, I'm evaluating the mother's emotional status. Does she have family with her, or is she completely independent? And what does she have to say about her family support? Maybe they stepped out for the assessment and they're coming back soon, or maybe she doesn't have anyone with her. I would also kind of gauge how she responds to the baby. Is she happy, or does she seem like kind of withdrawn and not really care? That might be a sign of like postpartum blues or depression even. And then I also want to be on the lookout for any nonverbal cues, like if she's redirecting any questions I ask about family or the baby, if she seems irritable, or if she becomes visibly upset. So beginning the assessment, I would assess for levels of consciousness. The patient is awake, alert, and oriented ×3. She's sitting up in bed, and she correctly answered her identifying marks, like the name and date of birth. I would also ask her how she's feeling, and then ask if she's in any pain or experiencing any pain, and I would take her through, if she says yes, I would take her through the PQRST pain evaluation scale. P being any provoking factors, anything that makes the pain better or worse. Q would be the quality of pain, if it's dull, if it's aching, if it's sharp. R is for region or radiating, where the pain is being felt, and if it's traveling anywhere. S for severity of the pain, I would ask her to place her pain on the 0 through 10 pain scale, 0 being no pain at all, 10 being the worst. I would also, T for time, when did it start, is it constant or intermittent? And then the U is how does it affect you? Is it affecting her vital signs, increasing them? Or is it affecting how she completes her ADLs, if she can't complete them at all because of the pain, if she's showing any visible signs of guarding or facial expressions. So to start off, I would first listen to the heart and lung sounds. Obviously the patient would be supine position, so I could have access to her, listen to her chest and lungs. However, my patient is uncooperative today, so I will be verbalizing where I will be listening as I pretend to place the stethoscope on him. First, I would listen to the aortic valve, which is the second intercostal space, right sternal border. And I'm listening for clear S1 and S2 sounds, noting for any swishing sounds, which could be signs of a murmur. I would then switch over to the pulmonic valve, which is the second intercostal space, left sternal border. Again, listening for S1 and S2 sounds. I would go down to Erb's point, which is the third intercostal space, left sternal border. And then I would go down to the tricuspid valve, which is the fourth intercostal space, left sternal border. And then lastly, I would listen to the mitral valve, which I may have to lift the mother's breast to listen there, but it would be the 5th intercostal space, left mid-clavicular line, excuse me. And again, all those places I would be listening for clear S1 and S2 sounds, noting any swishing or any signs of a murmur. Onto the lung sounds, I would listen in a Z pattern, starting in the right upper lobe, listening for a full inhale and exhale, and noting any signs of crackles or wheezes. The lungs were clear to auscultation, and the heart sounds were all good. There's clear S1 and S2 sounds with no signs of swishing or murmurs. I would then move on to a breast examination. I would ask the mother if she is breastfeeding, and whether or not she is. I would ask if she's feeling any breast heaviness or tenderness, as those are normal signs for the mother to experience. I would ask if she's also seen any colostrum being produced, which is typically a yellowish color, and that's the first signs of breast milk coming in. I would inform the mother that I will be exposing her breasts for an examination. I would first be inspecting and looking at the nipples to be clean and intact bilaterally and note any cracking. I would also look for any distended veins, which could be a sign of engorgement. I would then begin palpation. So upon palpation, I would note any signs of firmness, tenderness. Tenderness is a normal finding again. I would note if they feel soft or firm, as firmness could be a sign of engorgement. I would take note of the skin temperature. It should be normal to the body temperature, and then I would recover the mother after the breast examination. I would then check the upper extremities. I'm looking for any signs of edema. I would palpate to do that, make sure that, check the capillary refill. That should be normal, is less than 2 seconds. So I would do that bilaterally. I would assess if the mother had an IV site. I would assess the IV site, looking for signs of infection or infiltration, and just do a generic skin assessment, looking for any sores or bruising, or and making sure the temperature is equal bilaterally. And then I would also check the brachial reflex. So I would hold the mother's elbow or the back of the forearm here, and place my thumb on her inner elbow, on her inner elbow, and then I would lightly tap my thumb with the reflex hammer to elicit the brachial reflex in the arm. I would do that bilaterally, and it should be +2, which is normal. So after assessing the upper extremities, I would then look at the abdomen and do an abdominal assessment. First, I would be inspecting, making sure the color is uniform and equal to the mom's skin tone. There's no any discolorations or anything. And if she had a C-section, I would assess the wound site for any signs of infection or anything like that. And then I would auscultate for bowel sounds, starting in the right upper quadrant, going to the left. Starting in the right lower quadrant, moving to the right upper, across to the left upper, and then down to the left lower. I would listen until I hear a bowel sound in each quadrant. And then I would also palpate the right upper quadrant for the liver, as I should not feel it. If I do feel the liver, or if the mother's in any pain, it could be a sign of preeclampsia, and that would be not good. So after completing an abdominal assessment, I would then go on to assess the uterus. I would palpate for the fundus, and I want to make sure that it's midline and firm. So I would place my one hand at the base of the uterus, and the other hand I would palpate the upper abdomen looking for the fundus. Again, it should be midline and firm. If the uterus is boggy, it could indicate further complications like a postpartum hemorrhage, uterine atony, or any retained placental parts, which is not good. If the uterus is not midline, that could be due to a full bladder, and so I would check the bladder for fullness, as it could be displacing the uterus from properly involuting. Depending on when the client gave birth is how I would determine where the fundus should be on the abdomen. It should typically decrease 1 centimeter each day postpartum. This client happens to be 2 days postpartum, so I can determine that by 2 finger breaths and looking at the umbilicus or the belly button. I would put 2 finger breaths below it, and that's where the fundus of the uterus should be. If the uterus is not involuting properly, I would contact the physician immediately, as there could be something else going on. Again, like a postpartum hemorrhage or any retained placental parts. So after the abdominal and uterine assessment, I would then go on to assess the lower extremities. I would be looking for any signs of edema just by palpation, if it's pitting or not. I would check the capillary refill in the toes. It should be less than 2 seconds, which is normal. I would also just do another generic skin assessment, looking for any sores, bruising, and making sure the temperature is equal bilaterally. I would check the patellar reflex, which is when I would support the mother's leg right behind the knee, and then ask her to relax her calf and foot. I would then, using the reflex hammer, try to elicit a patellar reflex response just by gently tapping the knee. And then I would extend the mother's legs all the way flat and check for a Homan sign. So again, the legs should be extended flat on the bed. I would gently press down on the mother's knee and ask her to flex her toes towards her own body. If the patient feels any pain or tenderness in the calf, that indicates it's a positive sign and indicates a blood clot within the calf, which is not good. It could break off and you cause other issues. So if it's a positive sign, I would contact the physician immediately. So after assessing the lower extremities, I would then move on to a vaginal assessment. I would put on gloves first, hand hygiene, gloves, and then I would inform the mother what I would be doing. I would inform her that I would be exposing the vaginal area and verbalize everything that I would be looking for and doing. At first, I would assess for any lochia. I would be looking for the amount on the pad. If it's scant, mild, moderate, or a lot, I would compare that to days postpartum. So the first 3 days postpartum, the lochia should be bright red, very similar to a menstrual flow, which is normal. The next few days, it would become watery and more serous, and by the 10th day, it should be thin and colorless. And then I would also note any odors of the lochia, as that could indicate an infection. Still doing a vaginal assessment, I would look for if the patient had an episiotomy or any lacerations. I would check for them. I would check proper healing of the wound, looking for any signs of infection or inflammation in the area. Also, if the patient had an episiotomy, you most likely have sutures. And I would make sure they're intact and make sure there's no suture sloughing. I would also ask the patient if she's experiencing any discomfort in the area, if it hurts, just laying there. So I could provide her with ice packs or, even pain medication. So while the patient is exposed, I would turn her in the bed so that I can do a rectal assessment as well, and looking for any hemorrhoids. Small hemorrhoids are normal. She just gave birth. I would ask about her daily bowel function and flatulence, as you don't want the patient to become constipated. If there's no bowel movement by the second postpartum day, I would discuss mild laxatives with the patient. Also encourage her to increase fluid intake and selecting fruits and vegetables from the meal menu. So once the assessment is over, I would place her back supine on the bed, change the perineal pad if needed, and any, if the pad under her is saturated, I would change all that out. If need be, I would take the gloves off, perform hand hygiene, replace all the covers on her. If the patient happened to have a cesarean birth, I would check the incision site and ask if she's having any pain or itching at that site. I would also be looking at the incision site and noting the location. Was it a transverse or a vertical incision, and where on the abdomen it was. I would also be looking if there's a dressing over top. I would note if there's any discharge and the color of the discharge as well. And I would note the margins of the incision and if there's any signs of infection, like inflammation or redness. Maybe she had an epidural. I would also check the epidural site on the back while I'm doing the rectal assessment, making sure that's not infected or infiltrated or anything. Again, if the patient had a epidural, she most likely has a Foley catheter. So I would look at the urine quantity, note the amount, and then also look at the color of the urine. Is it clear? Is it yellow? Is there sediment? All that kind of stuff. So that brings us to the end of my assessment on the postpartum mom. I would recover her in the gown and any bed sheets that I took off during the assessment. I would raise the bed rails, lower the bed to a safe position for her, and then also place the call light within reach. I would ensure that she's in a comfortable position before I leave and also ask if she needs anything. I would perform hand hygiene again before leaving the room and then document all my findings as appropriate. I just wanted to say thank you. I hope my patient was okay for today. Fortunately, I don't have any family here with me today who was able to work with me, so I had to work with my dog. I hope me verbalizing everything that I would do was okay for this assessment. Thank you.